Hello, everyone. I'm just gonna give about 10 seconds to let the everyone in the lobby get into the webinar. Okay, I'm gonna open our webinar for our lunchtime webinar. My name is Megan. I'm from the Alberta Association of Optometrists, and I'm here to introduce your noon webinar on diabetic eye health for health professionals. It is my pleasure to introduce our speaker, Dr. Sophia Leung. She is the principal optometrist at SEMA Eye Care, a tertiary medical and surgical center in Calgary, Alberta, and the current president of the Alberta Association of Optometrists, a diplomat of the American Academy of Optometry, and she holds adjunct faculty positions within University of Waterloo School of Optometry and Vision Science and Northeastern University of Waterloo School of Optometry and Vision Science and Northeastern State University, Oklahoma College of Optometry. Um, Before we dive in, we're going to do questions at the end of the session. Just drop them in the Q&A box and I will help moderate them with Dr. Leung. And yeah, without further ado, I'm going to hand it off. Thank you.
All right. Well, thanks so much, Megan, and welcome to all. I know some of you are catching this kind of at your lunch break, so I hope the day has gone well for you all. If it hasn't, hopefully it turns around for you. But yeah, I'm excited to talk about this. We're talking about diabetic eye health today, and hopefully this will equip you all with some practical things that hopefully even in the afternoon, if you engage any patients that have diabetes or are maybe have some suspicion of that, you can have some things to keep in mind right away. So let's go ahead and dive right in. So, just, Megan gave me a nice intro already. Just a little bit about SEMA Eye Care, where I work. We are a surgical practice specializing in cornea, cataract, anterior segment, but really any kind of advanced disease. A lot of it is kind of triaging a lot of the times and making sure that patients are able to get to where they need to go, whether it's surgical or medical, that kind of thing. I also currently am the president of the Alberta Association of Optometrists as well. These are my disclosures. These are the companies that I speak and I consult for. And as far as this, I did receive support from the Alberta Association of Optometrists for this presentation as well. As far as the biases, there are no pharmaceutical products or medical devices promoted in this talk, and all treatment and monitoring recommendations are evidence-based. So what are we going to be talking about over the next little period of time? We're hoping to better understand the impact of diabetes. And I know many of you have probably heard about it in terms of diabetic retinopathy. It gets a lot of airtime, and as it should, because it can be visually impactful. But I'm hoping to be able to highlight a little bit more on some of the other structures that you may not be aware of, but are very common in terms of what it means for someone with diabetes and how it impacts their ocular health. We're going to also talk a little bit about how we can all work together, those different supports, the pathways that are available, because there are lots of people with diabetes out there and there are lots of resources available. And we're going to talk about how we can work together. And even at the end, honestly, if there's anything that pops up that you're thinking, hey, this could actually be done better, please let us know. Please email us, let us know at the Alberta Association of Optometrists. Just like we have ideas on what we see and kind of what our doctors and members, deal with on a day-to-day basis. I'm sure so do you. And so if there are ways that we all can collaborate together, please certainly write those ideas down, send it to us, and we're more than happy to engage in conversation even after this as well. And then we'll learn about referral pathways and talk a little bit about what that pathway looks like in terms of the eye care space and how we can all work together to make sure that these diabetic patients are able to get the best access that they can and the best care that they can in Alberta. So let's do a little bit of a level set. So, obviously we're here to talk about the eyes, and here's just a little bit of a quick overview of these structures. We're going to be talking about four main areas today. Now, truthfully, diabetes can actually affect really any part of the eye. It just like it can affect really any part of the body. And so, it's no surprise here that there actually can be so many structures within this, this organ that you'll find that diabetes can be impactful. But we're going to talk about four. And in three of four, where diabetes can affect, you'll find that these visual impacts can often be permanent. And so there's lots of reasons why we're gathered here today to talk about this. So the cornea, the very front, kind of like the window into the eye, we'll talk about that space. The lens we know about, cataracts we commonly hear about, right? This is actually I'm kind of trying to highlight the retina here, so kind of this sort of reddish line around here. So not quite this whole entire post intermediate segment space, but the retina, which is where the diabetic retinopathy is very commonly found, and then of course the optic nerve. So we'll go through those four today. So starting from front to back, let's do that because my personal favorite, I did my clinical fellowship in the States in cornea. And so this is sort of my personal favorite tissue of the eye. And so, the cornea is really interesting because it's one of the most highly innervated parts of the body. And so when you have someone with a regular functioning cornea, if you think about if any of you have any had like an eyelash on the cornea, for example, it's there, right? Something's in it. Whereas opposed to if there was ever an eyelash on the conjunctiva, the white part of it, you wouldn't feel it as much, and so you might feel something's in there, but it wouldn't bother you nearly as much as on the cornea. And that's because the entire nervous system of the cornea is extremely sensitive. Think about your efferent and your afferent pathways. Well, the cornea is a branch off of the cranial nerve 5, and the ophthalmic branch is a significant pathway for sending signals into basically the feedback loop to ensure that there is healing. And so the cornea itself, we need it to stay clear, right? Because again, the light comes through the cornea is kind of the first way to go. And without it being clear, then vision problems can happen. But it's also a sort of a barrier for bacteria to get inside. And so for lots of reasons, we need that cornea to be healthy. So what happens then is this nervous system, it promotes regulation for healing purposes. So then in diabetes, what you then get is then you have this deposition of glycation products and microvascular damage, as we know. We know this process very well in terms of how diabetes affects the body. And so when you have these microvascular damage, well, it's interesting because the cornea is actually avascular, right? And so you might be thinking, well, that doesn't seem like it's going to be a big deal. If there's no vasculature in the cornea, then what does this particular micro damage do to the cornea? Well, it has to do with the nerves, actually. So when the microvascular damage occurs, then the nerve plexus is going to be impacted by that as well. And so when you have these damaged corneal nerve endings, you actually get reduced tear secretion, which does have different, nerve growth factors, different processes that will help balance the entire ocular surface. When that becomes reduced or not functioning well, then you get more oxidative stress from hyperglycemic conditions. And so we've all heard of the term diabetic peripheral neuropathy, right? And you can think of the eye as a peripheral organ. And so in this case, on the cornea, diabetic keratopathy, or the cornea being affected by diabetes, can also occur as a very similar process with diabetic peripheral neuropathy. And the statistic that we know is that 46 to 64% of diabetic patients can have diabetic keratopathy, or actually they do have diabetic keratopathy. So think for a second, for those of you who were in clinic this morning, how many patients that you saw had diabetes? How many diabetic patients did you manage this morning? Or for those of you who can think about in the week, right? If those of you who have the day off, for example, think about in a week, how many diabetic patients you encounter. I'm guessing probably a lot, right? And if you now think about that, it could be that half or even more than half of these patients have some version of diabetic keratopathy, then this is a pretty significant amount of patients, right? And so this is a big issue because it's actually not uncommon at all for optometrists to suspect a diabetic process when they see poor healing corneas. And so you see these pictures on to the right side here. This first picture, this is from Dr. Michael Yu up in Fort McMurray. We have basically a corneal ulceration here. Now, it's off to the periphery, and again, a cornea should be pretty sensitive. Something like this should be pretty bothersome, but in diabetic patients, oftentimes that they won't really feel that. And so they might say, well, my vision's kind of a little bit blurry, maybe a bit hazy. And then over on this side, which looks a little bit benign in the sense if you're thinking about, well, it's not in the visual axis, so it's not probably going to be causing a lot of visual problems. There's some dry patching here. We call this SPK, or superficial punctate keratopathy. And so essentially that is just a little bit of breakdown of tissue. And so when it's in these kind of, mild stage, I put quotations on it, the issue is if the cornea does not feel that there is a problem there, the patient themselves don't know that there's a problem there, then there isn't really any motivation to do anything about it. And so what happens is that it ends up going over to this side. And this is what I see in my practice. And so this is actually a patient of mine who has diabetes, quite uncontrolled. And the chief complaint was that there is some blurry vision. And yeah, blurry vision is probably part of it. But if someone had a normal healing cornea, a normal feeling cornea, this should be extremely painful. And the risk here is not really just the vision problem. The risk is that this is actually going to scar when it heals over. It's a big risk for a bacterial infection, microbial infection, and then it can lead to a lot more problematic things as it continues to escalate. And so, oftentimes patients may only describe blurry vision, watery eyes, foreign body sensation, general discomfort, not realizing at all that there is a much more insidious process at play. And so this is routinely tested for in a comprehensive eye examination, checking the health of the cornea, sometimes even further testing like corneal sensation testing. This can be all done off of an initial examination. And most of the time, these further assessments for a medical reason do have Alberta healthcare coverage. And so, if there is no existing diagnosis of diabetes, it's not unusual at all for these patients to be referred by the optometrist to their family doctors, to their nurse practitioners, to their primary care provider, sometimes even to pharmacy to see if their medications are doing okay. Whoever that is, just for labs and testing, because it's not uncommon at all for some of these patients to be walking around not realizing that they have diabetes in their body. And so moving behind the cornea a little bit, now let's talk about the lens. So we saw this patient before, right, on this left side. So I'm going to have you focus just a little bit behind the cornea now over at this structure called the lens. And so this is a pretty normal lens. The lens here is looking clear. There's not really any sort of opacification or cataract, but you can differentiate that with these two photos over here, where obviously there's something kind of getting in the way. And so the lens structure itself has different concentrations of proteins or crystalline, and it means that water content and the refractive indices of that lens will depend on the glycemic levels. And so what happens in diabetes here? Well, the sorbitol then can accumulate in the lens, which can cause a bit of a hyperosmotic effect or fluid infusion. And then that osmotic stress will affect those lens fibers, damaging the lens cells, and it can change the index and the opacity. And that's where sometimes you'll get patients when they have different diabetic swings, their prescription, or in their mind, subjectively, it'll be their vision will also swing as well. And some of this can be regulated in the sense that it can be reversible. So you might be thinking, okay, well, then once they get that sort of regulation set up, then it's fine, right? But the problem is that once these swings happen enough, or once the indices change enough, then there actually can be an opacity shift, and that leads to your cataracts now. Now, some of you might be also kind of thinking, well, I mean, there's cataract surgery, right? So this is the one of the four that we talked about earlier, where it is a sort of a treatable condition. So thankfully, in kind of our technology and kind of our, more modern healthcare, yes, cataract surgery is a big part of, eye care right now. Diabetic patients do tend to have a bit of a 5 times more likelihood of developing early cataracts. And so how that plays out in terms of the pathway is that any surgeon will tell you that diabetes can complicate things, right? And this is very much true for cataract surgery. So I work at a cataract surgical facility, like I said before, and a lot of that triaging is to really make sure that whatever risk factors are there are managed. But before that point, before a patient is referred into the SEMA eye care, for example, there's a lot that happens on kind of the primary space, as you all know. And so in the eye care side of things, an optometrist will take a look and see on the eye care side, the refractive error. So are they seeing well because the prescription has changed? Are they seeing well and the prescription has changed because of cataract development? All these questions are answered prior to that. And it may be so that someone may not actually need to have cataract surgery yet, but we know that they have cataract surgery, they have cataracts. And so the question will become, at what point do they get referred on? Because as many of you may have encountered or may have heard from, whether from your patients or from your family members, or maybe yourself even, that cataract surgery wait time can really vary, right? And so that means that we need a proper triaging to take place to ensure that these patients, if they're not ready for surgery yet, but they have visual symptoms, that there can be still therapeutic devices like glasses, like contacts, for dry eye disease, for example, which is very prevalent in diabetic patients, that all is managed to maintain the sort of integrity of their vision. And so all of that is typically going to be done in the primary care space. And then when it gets referred on to the cataract surgeon, there's triaging that happens, including any other diabetic kind of eye health that is needed as well. So it's very not uncommon at all that we also will engage with our retina specialist, for example, to make sure that any swelling or any macular edema, all of those things are also managed just in case there could be an increase in risk of swelling or complication after the surgery as well. Then let's say the patient then gets their cataract surgery, then of course there's post-operative care. And it's very common again for optometrists and ophthalmologists to co-manage together to make sure that those potential risk of complications are managed. And then once they're out of their post-op period, then there's that reestablishment of the comprehensive eye examinations with the primary care and primary eye care team, because of course, as we are learning today, that there are lots of different structures that can be still impacted beyond just that cataract issue. So this is one that is fairly well understood, but we have to be watching for, every touch point along this particular pathway is critical, because optometrists, when they're part of this pathway, will be watching for persistent inflammation and swelling in the eye, macular edema, poor healing of that cornea. So, with cataract surgery, they're usually in more standard surgical approaches is an incision that is made on the very edge of the cornea. Well, if you have a cornea that doesn't know how to heal, then that's a problem, right? Because then every single incision, every single sort of maneuver is going to now risk for poor healing. So that can be a complication as well that has to be managed. Dry eye disease from medications and reactions, all of these things are being managed and watched for by the optometry and ophthalmology team. And that's why it's really important to, make sure that if you have a patient that is going for surgery, just make sure that they're getting all of those checkups as well. And it really is helpful as well for us to know how well their diabetic control is from your side of things as well. Whether it's from, their, how well regulated their blood sugar levels are, or if they're in the middle of changing some medication, all of those factors actually help us to be able to properly plan kind of the surgical, but also instead of the primary eye care provision of that as well too. So let's move a little bit further back. So I'm going to save the retina at the very end because I know that we've heard a lot about it, but there's maybe some information that I want to be able to update you on. But let's talk about the optic nerve a little bit. So the optic nerve is essentially a tissue. So from the brain side to the eye side, what happens is that it's technically a neurological tissue. So it's brain tissue that is when it goes into the eye itself, there's a conversion at the lamina curvosa, which basically becomes ocular tissue. So obviously you can understand this is a very important tissue because it translates. The optic nerve's job is to translate the information. So the light coming in will hit that retina, and then it'll get converted to an electric signal. And then now the optic nerve will translate it to essentially along the pathway through the optic chiasm, the optic tracts, all the way to the back to the visual cortex. And then now the person then interprets that as vision, right? And so you can imagine if that optic nerve is damaged in any way, then the translation of that information is going to be poor. So it doesn't matter if you have a good cornea, a good lens, a good retina. If that optic nerve can't translate that, then the vision will not happen. And so absolutely diabetes can cause optic disc damage. The optic nerve itself, it houses the central retinal arteries that runs right through. It also has, a nerve plexus that runs around that as well. And then it translates into the nerve fiber layers of the retina. And so when you have essentially, neovascularization of the disc, where you have, and you don't really, I'll show you a different picture that has it there. But when you have a situation where the optic nerve is not able to have the proper blood supply because of vascular damage, then a lot of different things can happen. You can get ischemia there, you can get swelling there. And so that vascular wall damage and disruption can result in transient fluid leakage, which then leads to recurring swelling of the optic nerve. We call that diabetic papillopathy. And in certain cases, it can show up kind of like this is a situation of a non-arteritic ischemic optic neuropathy. And it is true to some extent, and let me go back a little bit. Diabetic papillopathy in some cases can be self-limiting depending on the glycemic control. But over a third of these patients will progress to a more serious version, which is an ischemic optic neuropathy with permanent vision loss. And so what we see here is that, let me kind of outline sort of what we're looking at here. This is the optic nerve, and you can see that the top half here, the border of that optic nerve is swollen. And so we can tell by a couple ways. We can tell the actual delineation of where the optic nerve comes in terms of the retinal tissue. You can see how sort of fuzzy it is, right? And so that's from the swelling, the fluid that's kind of leaking into there. You can also see how the striations are actually starting to extend into the retina as well. And that is basically extending into the nerve fiber layer, which is going to transit to where the vision loss is going to happen. And so over here, this is Dr. Wagner's patient from Brooks. The optic nerve functions kind of in like an upside down manner. So what that means is that if the top half of the optic nerve right here is affected, then and it translates into the nerve fiber layer in the superior portion of the retina, it's going to show up in the inferior portion of your visual field, which is exactly what you see here. So this is actually a right eye field, sort of the blind spot over here. But what happens then is this arc here that you see is actually the bottom half and going towards the nose. So we call that an inferior nasal defect, which directly translates to the superior portion of the optic nerve. So why am I going into all of this? Well, because it depends a little bit on what part of the visual field becomes affected, right? And so this is actually a 30-degree sort of peripheral vision test. The center 10 is right here. So if you have, let's say the other eye is doing okay, then arguably this patient will function just fine. This diabetic patient will may or may not actually know that their vision is impacted. But the problem when you have someone with an NAION, so not only are 30% of these patients with diabetic retinopathy already at an increased risk of NAION, the second eye can often get involved as well. And there's a problem there because if the other eye now gets involved, then now this is going to be a very dysfunctional vision problem, right? And so, the issue with this is that this can happen very quick as well. This could be a patient who has had some diabetic retinopathy, it's been stable for a long time, and then a spike goes or the vascular damage hits a threshold, and then all of a sudden their optic nerve is showing some problems here. And so this is the critical nature of the communication between oftentimes optometrists will ask, well, how is your diabetic control going? How is your A1C going? And we will get some kind of response. And whether that response is accurate to kind of what the actual situation is and how many patients have you had that will say, my blood sugar levels are good, right? And you look at their net care and you're like, well, it's been all over the place, right? And so, this is kind of a part where if there is a patient that you have that you're a little bit concerned about their blood sugar levels, they're having some visual problems that are kind of nondescript, optometrists are going to be more than happy to take a look and double check that a lot of these things to make sure that, of course, optic neuropathy is not part of the picture. Now, another thing that we have to be cautious about too, let me show you a different patient. This is coming in from Dr. Michael Yu again in Fort McMurray. So this is a different kind of visual field. It's at 10 degrees. So this is right in the center now. Remember how the last one, I'll show you again, the center was fine. So again, this patient may not know that they have visual problems. To be honest, this person may not know that they have any visual problems either because there's two eyes and they're technically you could argue that they're seeing. And so this is the right eye here, left eye on the other side. And so on the right side, you can see the central 10 degrees of vision here is pretty much blacked out. And so this is a problem. This is a condition of diabetic associated glaucoma here. The left eye, you could argue that there is some visual field defect. So functionally, this patient might know that they don't see very well, but they can still kind of get by. But now we have a bit of it's kind of like a ticking time, right? And so we're trying to figure out how we can try to help prevent or slow down the loss of tissue. And so, for example, let me talk a little bit about glaucoma. Glaucoma initially oftentimes doesn't present as anything. If it's going to be peripheral vision loss, a lot of times a patient won't know until much further along when their central vision like this is affected. But we also can think about diabetic strokes too, right? And so diabetic strokes can also result in optic neuropathy, where there can be some significant consequences depending on what area of the brain is impacted. And sometimes there can be that the only consequence of that is in vision. And so now we're talking a little bit about quality of life, because what happens if a patient, for all intents and purposes, otherwise everything is healthy, but just their vision is impacted? Well, these patients need help navigating these new changes, right? And so if you had a patient who has gone through some significant diabetic changes, it's really helpful for them and for us to know what their actual subjective vision is like, not only just how they see in terms of visual acuity, but what is their peripheral vision management like? Because we are able to detect this to monitor for progression and manage these cases with continual communication to the patient, connect them with resources, as well as to communicate with you as their allied healthcare team to make sure that whatever is important for them to know, including, hey, your blood sugar levels are too high, it's affecting this as well. There's a lot of different, not really pressure points, but different encouragement points that can help someone be more on top of their diabetic health control. So again, visual fields, dilated fundus exams, OCT scans, all of that are screened for and tested in an initial comprehensive eye examination. And then the further testing after that, depending on need, can be ordered further that after from the initial examination. This frequency could be anywhere from 3 to 6 months to yearly, depending on the severity presented at these exams. But if you do have someone that you're thinking, you know what, something may be not going so well in terms of their symptoms, send them back in to see their optometrist. There's always an ability for them to be able to get an assessment, even in between kind of their more frequent follow-ups as well. So lastly, we go and land on the retina now, the diabetic retinopathy. So some of you may have heard a lot about this, and some of this might be a little bit newer. So let me just kind of do a quick recap for this. So there's a couple of different categorizations of diabetic retinopathy. And so non-proliferative diabetic retinopathy tends to be the one that can be more monitored because it may not always convert to something that needs surgical attention. But what we see here in this eye, coming from Dr. Wagner and Brooks, you've got a couple of microaneurysms. These are these little red spots here. But the retina has different layers too. So you can have intraretinal, deeper hemorrhages that can also show up there, showing that there is that microvascular leakage. You can also have infarcts in the retinal tissue where we're now starting to get a little bit of ischemic reaction here. So these are the kind of the white spots that you see here. And then you can get retinal edema, so fluid building up in the retina, which can happen in all sorts of places in the retina, but where it will be more visual impactful is right in the center at the macula. And when that happens, a patient usually will be able to tell. They may not know that it's from diabetic retinopathy, but they'll know that the vision has had some changes. And so again, oftentimes it's not unusual for optometrists to be able to see this, and a patient may not even know that they have diabetes, or they may be newly diagnosed. And it's really important to be able to now establish a monitoring schedule for how to see if the retinas are getting better or not. But where it becomes a little bit more complicated is when it becomes proliferative diabetic retinopathy. So let me show you that. So here, now the proliferative piece means that there is now neovascularization that is happening from chronic ischemia from diabetes. And so there's two reasons why that's not so great. So we like blood in the right places, right? I mean, that's a pretty, it's reasonable to understand why that is. But when blood is not in the right spot, and in the case of neovascularization that is not supposed to be there, this neovascularization can happen in all sorts of places. It can happen at the optic nerve, like we talked about. It can also happen in the drainage system of the eye, which can then cause the drainage system to be blocked. And so the pressures will go up, then you're at a diabetic or glaucoma risk. It can also happen in this way and the retina as well. And when it happens at the retina, it can start to leak blood in all the wrong places. And it can leak in the retina, it can leak in front of the retina, and it can leak in the vitreous. And when that happens, there can be some severe visual problems, but it can also add some toxicity to the actual tissues that's there as well. Because when blood is not in the right place, it can be actually damaging to the tissue unto itself. And the second piece of it, as you can see here, is this sort of whitish tissue here. So here you can see some neovascularization. I don't know how well it shows up on the screen, but this kind of reddish, smaller blood vessels, that's not really supposed to be there. These big ones, sure, but these small ones are not really supposed to be there. And this whitish tissue is actually fibrotic contraction. And so you can actually tell, I mean, this is not obviously not a 3D photo, but it's actually pulling upwards towards the viewer. So if we were looking directly into the eye, you could see the tractional pulling coming towards you. And technically, you see the macula right over here. The macula, if it's not that affected, the vision may not be that impacted. But the concern is that when that fibrotic tissue, and let me go back for a second, the optic nerve, as long as it can translate that electric impulse from the rest of the retina, then this patient can technically still see. But a lot of times what happens is that fibrotic reaction is actually going to be damaging to the optic nerve. And so now you have a visual perception problem. And then if that tractional pulling then pulls even harder, and now we're talking about retinal detachment or a tear, and it takes that macular area with it, then this is bad news bears. This is a situation where a patient will definitely know that the vision is impacted, but this is going to be going to our retinal colleagues very quickly to try to get that treated. Sometimes they do get some of that vision back, sometimes they don't. And so these are very permanent blinding situations, and we really want to try to avoid this. So what do we know about risk factors then? What does control look like and management look like? Well, we know that the longer you've had diabetes, the higher the chance or the higher the likelihood of getting some kind of diabetic retinopathy. And The higher glycated hemoglobin was an independent factor for the development of proliferative diabetic retinopathy. So you can see here kind of how the numbers kind of play out. Your type 1s will tend to have a little bit of again, across the board, the longer you've had it, the more likely you would be having diabetic retinopathy. Here's the interesting thing, the insulin, whether you're on insulin or not on insulin, there's a bit of a difference in kind of the percentages of retinopathy as well. My understanding to this, when I was digging a bit deeper on this, was that it could be, it's not so much that the insulin itself is causative, but more so the status or severity of the diabetic control requiring insulin or not. Because actually insulin in applied in other cases in the cornea as well actually can actually be very promoting of corneal healing. So I don't believe this is saying that insulin is causing the diabetic retinopathy, but more so that for those patients who are requiring insulin, that they actually are a little bit in poorer shape at the longer duration of time. But this is why this matters, that every 1% of reduction in the hemoglobin A1C corresponded to a 35% reduced risk of retinopathy. So, one of the issues I often struggle with is when a patient comes in and they say, I ask them, how are things going? What are your blood sugar levels at? And they're like, oh, yeah, it's good. It's around like a 7 to 10. And I'm kind of like, I mean, that doesn't happen often, but I'm exaggerating a bit. But, 7 to 8, 8 to 9, and these big ranges, right? And so sometimes it kind of tells me that maybe the exact number is not known. And so I'm very aware that what a patient's understanding of their diabetic control might not be the same as what you as a provider might think. And so that's where that communication is really helpful. And we'll talk a little bit about reporting mechanisms kind of later on. But one of the things that is helpful for communication purposes, if you find that it's helpful to you, if to know what the patients are reporting, you can let the optometrist that you're working with know about that. Like if you prefer for us to actually write, this is what the patient thinks that their blood sugar level control is, and kind of have like a very short, like number or kind of quick report on how they believe that perception to be, excuse me, then that might be able to help you to figure out what the conversation when you're in office will be like as well. And we're more than happy to help with that because with those the metric around that helps us to know if someone is sitting at like a 10 or if they're saying that it's all over the place, then I kind of already know what I'm not expecting to see, but I'm going to be screening for. And so a lot of that discussion for what is helpful to you, make sure you have the discussion with the optometrist you're co-managing with, because we're more than happy to make sure we tailor it to kind of what is helpful to you, especially when you're going through a lot of patients, and what is helpful for you to have in the information, what's not helpful, all that can be very customized. But let me talk a little bit about AI for a second. So we know that AI is getting better and better at detecting diabetic retinopathy. Some of you may even have some kind of an AI system in your office now. But really, I want to really emphasize that this is only part of a diabetic eye health assessment. As we already know, there are more structures than the retina involved. But here's also another limitation currently about AI. And I actually really like AI in healthcare. I'm very excited for it. But I do think that there's limitations and there's a proper way to use it so that it adds to the value of clinical care as opposed to incorrectly replacing it. But let me show you the screen grab here. This is a screenshot of what the IDXDR, just a company that has been in sort of the AI space for diabetic retinopathy for a while. So what the AI software will do is it'll try to detect based on a large image data bank on more than moderate diabetic retinopathy. And that's a very specific classification because the miles are less of a concern under the outputs because it's the moderate that has a higher risk of proliferative, and then more than moderate would be moderate severe and then proliferative. And so there's a consideration that these patients would need to be then established or referred on with an eye care specialist. And so the technology is getting better and better and truly more accurate. But let me show you a Optos wide field photo that's often going to be commonly found in an optometry practice. So what you see here is a patient who has clearly had proliferative diabetic retinopathy in the past. And how I know this is because of these laser scars that you see here. And these laser scars are done by a retina specialist, and it's actually purposeful damage to the retina to try to stop neovascularization from happening. So again, neovascularization, when it's leaky, if it's going to cause fibrosis, we don't want any of that. If it starts to tug on the retina and starts to pull that all down, that's a big problem. And so you can see not only in a small area, but this actually patient is actually Dr. Giles from Grand Prairie has noted this is actually more than what we see here, but this is just the photo and the way that it was captured. But this is an extensive area that was treated. And so this tells you that you can even see some blot hemorrhages here. You've got, they're scattered there. So this patient is it's more managed now in terms of the proliferative diabetic retinopathy stage, but definitely not completely out of risk either, right? So going into the further towards the optic nerve, you also have, some Ross spots here, some different aneurysm changes and things like that. So when you look at this, hardly anybody would say to this that this patient has no diabetic retinopathy or that this patient does not have more than moderate diabetic retinopathy. But the issue that we have is that currently the AI systems are only looking at about the 30-degree window in the posterior segment. And so while true, the central area here, we're not as concerned immediately for vision loss right now, even though there are some risk factors. It would be very inaccurate to say that this patient would get a scan and say, you don't have more than moderate diabetic retinopathy in your posterior segment, you're good to go. And this can be very misleading. And that's the issue that I kind of take when we, I guess, abdicate our clinical responsibility to fully on eye care. And I'm not saying anybody is. It's just my caution around that is that just because someone has had a screening does not necessarily mean that they've had a comprehensive diabetic eye health assessment. And so studies actually report now the cost effectiveness and improved outcomes with engaging optometrists in diabetic retinopathy screening and testing. So just keep this in mind as we see different companies coming in and promoting AI screening tools or even kind of in some ways some virtual options. I'm excited for what technology will be able to offer us to be able to help reach the patients that currently may not be able to access care as readily. But the issue is that it's still currently not a replacement. I don't think it ever will be, but we do have to understand its limitations to make sure that everything else is not getting missed, especially knowing that a diabetic eye health assessment is not just retinopathy, right? So, what does that start to mean in a practical sense then? This is the Diabetes Eye Care Pathway Toolkit, which is on the Alberta Health Services website. The only thing it's very busy, so I mean it's available on the website. But the only thing I will say to that is that a lot of optometrists are actually monitoring the up to moderate and higher levels or more severe non-proliferative diabetic retinopathy and macular edema as well. And then, of course, the proliferative diabetic retinopathy, vitreous hemorrhaging, that will need to go to a specialist, typically a retina specialist for any kind of surgical care. And so a lot of these are hard to differentiate if you don't have the proper equipment for it. But when in doubt, just speak to your optometry team. Just like you are all in that primary care provider space, we also have a primary eye care provider space. And the triaging here and the separation of kind of the categorization can be very readily, easily done within the optometry offices. And we do have kind of our ability to know what the wait times and everything is like between the retina specialists as well. So it just helps with better, kind of more efficient triaging as well. But kind of a different version of the same slide from before, essentially optometrists will test for and monitor for the progression or development of non-proliferative diabetic retinopathy. We can more than happy to let you all know about that as well, so you can make any adjustments on your end from what that looks like systemically as well. Any proliferative diabetic retinopathy or other retinal complications such as a retinal detachment or not even just retina, but even like optic neuropathy, diabetic papillopathy, all of these conditions that can happen in that posterior segment, we will typically then refer onwards for surgical care or more intensive care. And there's still a lot of management on co-management on whether it's post-operative or on kind of in between some of these big assessments as well, just to really critically make sure that these patients are getting their eyes checked as changes happen as well. The last thing I want anybody to feel as a patient is that they're kind of left out in the dark on their own in between follow-ups, right? If there is anything changing at all that you're seeing, that they're seeing, they're always more than welcome to call their optometrist and request a checkup as well. If any of your patients are not connected with an optometrist, a referral is actually not necessary. Optometrists can go and basically enter the patient pathway with optometry directly. But of course, as we all know, a referral process does help to build a reporting connection between you as a healthcare provider and then us as healthcare providers as well. And oftentimes, a referral is kind of a nice nudge for the optometrist or the patient rather to make the appointment. Sometimes that follow through is a little bit better when someone else is kind of encouraging to do so. And please know that optometrists are also saying that back for you as well. Things like making sure that they're going back to their primary care provider for follow up, checking up with with them if they have been lost to follow-up for diabetic follow-ups. It's a common conversation to encourage the patients to not only continue to see their providers for care, but to follow the management advice as well. So know that these conversations are happening often in optometry offices. But if you do, want to make a referral, we have these online printable forms that you can use to connect with your EMR. We also have tearaway hard copy referral pads as well that you can get. Just reach out to the Alberta Association of Optometrists, and we'll make sure that you get the whatever version that is going to be helpful for you. I use this website all the time. In a referral practice, it is still, very common that the patients that, if they're new to the area or maybe they were referred in by family doctors. I get referrals all the time from family doctors, nurse practitioners, pharmacists even as well. It's not uncommon at all for someone to not be established with a proper primary care team. And so this particular website is very, very commonly used. You can find the optometrist in your area, so you can put your own, like your practice postal code in there, and then you can take a look at all the different optometry offices near you. You can also have the patient put in their postal code as well to be able to find the different optometrists near them. But a very, very helpful feature to make sure that they're able to be connected with someone that can help take care of their eyes. And we've got lots of people. We've got lots of optometrists well spread out across the province. I wouldn't be surprised if there's an optometrist stone's throw away from where your practice is at. But we have over 120 communities covered across Alberta. We have over 900 optometrists, and we work very closely with our ophthalmology colleagues. They tend to be located more in the urban centers, and they're the triage pathway, the referral pathway in terms of access right now. We all feel a little bit of burden on healthcare right now, right? There's long wait times everywhere, and this is it's not untrue for ophthalmology as well. So the triaging process, getting these patients in through the referral pathway from primary care, secondary care to tertiary care, we're continuing to work on that. And so, if you have a patient who is not currently connected with an optometrist, we're more than happy to help. We are around, and we have resources to make sure that you can help them find it, or they can find it themselves where their closest is as well. And then one other thing about this too is that if you ever find yourself having patients coming in, not even on diabetes, but any kind of eye care needs that are more urgent or acute, your local optometrist nearby are more than happy to facilitate some kind of a referral pathway process with you. There are oftentimes lots of appointment slots in the day blocked for these kinds of things, and so especially if you have a situation where maybe it's an eye condition that you're not sure about, develop that referral pathway with your eye care team, and they with you as well. And it's a really effective way to prevent having to drive someone to, let's say, Rocky View in Calgary or Alberta Retina Consultants up in Edmonton, to be able to help better triage that system, because so much of that care can be managed at the primary care level with optometrists as well. So, kind of to wrap up before going to the question and answer period, this is kind of just a summary of what we've already been talking about. How do we all work together as a team? I do think a lot of diabetic patients, not just on the retinopathy side, from front to back, from the cornea, the lens, the optic nerve, the retina, a lot of these patients do need to be routinely monitored to make sure that their eye health is as optimized as possible. And so, that initial referral pathway to get them into the eye care portion, I think going into optometry to help get that triaging going can be really effective. Optometrists are happy to co-manage. We have access to Netcare to be able to make sure that the information that is on there, we can make sure we're kept up to speed on. And then that reporting preference, I think that's a really critical piece too, is whatever way that works best for you in your busy day, that is helpful for what pertinent information you want to know from us, let us know, because a lot of times now EMR systems are so sophisticated now that they can be customized. And so this is not a hard thing to do. That conversation to be had with your local optometrist in your community, very effective way in making sure that the important information is getting delivered in the right way. We do dilated examinations, we do photos and OCTs if needed. They do have Alberta healthcare coverage, but just a quick reminder that routine eye examinations are not covered between ages 19 and 64, but medically necessary examinations and assessments do have Alberta healthcare coverage. So with that, these are our references. If any of you are interested in any of these papers, we're always doing kind of a literature review to make sure that our information is up to date. We're more than happy to send that over to you. But I think I'll open it up to questions now to take on, anything that needs clarification or any further thoughts. I'm happy to take a stab at any questions that might come from you as the audience.
Thank you, Sophia. We have two questions that have come in already.
Okay.
So the first one is, should patients with diabetes limit sorbitol consumption?
Say that one more time. Limit.
Should patients with diabetes limit sorbitol consumption?
Mm. So yeah, I mean, I think it goes back into kind of the overall diabetic management, right? And so um, in general, I think is going to be a matter of making sure if it's going to be like a nutritionist, for example. There's lots of factors where if they're limiting one but ignoring the others, right? There's also natural fruit sugars, all the kind of things. So it's not really just going to be the one that's going to be the big trigger, but is really going to be looking at it more comprehensively. And that's where I will oftentimes talk with, and as one question I always ask will be, what's your diabetic care team look like? And I'm always really happy to hear if somebody is connected well with like a dietitian or nutritionist, just to be able to give them some suggestions on what that diet piece can look like, because it is really critical. Medications is one, but as you all know, the medication, the three-pronged approach, right? Medication, diet, exercise, all of that is really critical. So I guess in short, kind of yes, but I would say in the context of an overall nutritional approach, a balanced nutritional approach. Because what I don't want is someone to limit one and then be, swinging over to the other side and really increased in the other, because then you still end up having the same problems as well.
Thank you. Um, we have another question.
Sure.
So just a thought. If insulin resistance presents in the eyes, then adding insulin, which worsens insulin resistance, might put patients at higher risk of retinopathy.
Hmm.
And then their follow-up question is, would it be possible that someone with diabetes develops non-diabetes related retinopathy? How can
Yeah.
you tell if it is related to glucose levels?
Yeah. So I really like this question. So let me tackle the first one first. So the really interesting thing about insulin receptors on the cornea is that, or I should say it this way, the interesting thing about insulin on the cornea itself is that it actually functions totally different. And so what that means is that the insulin receptors and the glucose transporters they function very differently than the rest of the body. And so even if somebody is insulin resistant, the insulin molecule itself actually has healing properties despite that. And we also see this in many cases in the sense of epithelial healing. And so the insulin itself actually on the corneal epithelial cells, on the stromal tissue, it actually will encourage epithelial migration, whether or not a patient is insulin resistant or not. Now, this is actually an area of really increasing growing research. We're going to understand it a little bit more, but we know for sure that when insulin is applied to a diabetic patient, it can be very effective if they have a diabetic ulcer. Even if they have insulin resistance, it seems to also have efficacy. Some of our bigger, broader studies are going to be coming, so we don't have a lot of that information right now in terms of multi-center studies, but it is coming. And so that would be the slight difference there, is that it's not going to be so much that putting an insulin drop on the eye. And let me clarify that as well. We're not putting topical insulin drops on someone to treat diabetic retinopathy. This is right now more on cornea at this time, and arguably conjunctiva as well. But you pose an interesting point, but the difference is that the way that the insulin reacts on the cornea is actually very different than how it is when you're taking it for systemic as well. And then going to the second question, let me just go ahead and read it again. Would it be possible that someone with diabetes develops non-diabetic related retinopathy? Yeah, so absolutely. And this is also whoever is putting that question in, thank you so much. I really like that question. So yes, I mean, we know that diabetes can have comorbidities, right? And so it is very possible for someone to have, let's say, for example, hypertensive retinopathy, which is we can see it where the vasculature can look really tortuous. They can be at high risk of vein occlusions, arterial occlusions, all of those different things. So absolutely, yes, there can be a sort of a comorbidity situation where a non-diabetic related retinopathy can occur. So the question of how do we know? A lot of times with a diabetic retinopathy, there is a quote unquote kind of classic presentation. And I put that in quotes because, as you all know, there are different ways that things can present. But if I were to see, a lot of blot hemorrhages or dot hemorrhages in the eye, and then I also see, massive exudates somewhere off of a vasculature, then it's very likely that that would be more from hypertensive as opposed to diabetes. But if someone has both, then it's going to be really critical to assess both anyway because they do affect they can compound on each other. And so it's going to be less critical to identify, one and rule out the other as opposed to understanding that one is being affected. So let's say for hypertensive, that the hypertensive retinopathy is from that. And we would measure the blood pressure in office as well, but also that the diabetes might make them more vulnerable to those problems. And this translates even broader into your optic neuropathies, that kind of thing. So someone with an NAION, for example, a non-arteritic ischemic optic neuropathy, it may be from either blood pressure, it may be from, arteritis, it may be from a diabetic, and so it could be any of those things. But if they do have diabetes, then all the more reason for us to be aware that the risk factors goes up. And so it's going to be less about pinpointing just the one cause as opposed to understanding what their overall risk factor is going to be based on their risk profile.
Okay, thank you. Um, Next question. So all diabetic patients should have coverage for screenings and exams? Question, or do they need to have supplemental insurance?
Yeah, so the routine examination. So let me outline that part first. So routine eye examinations are have Alberta healthcare coverage under 19 and over 64. So it means that from basically 0 to 18 and then 65 and up will have Alberta healthcare coverage for routine eye examinations. Now, between 19 and 64, routine eye examinations, if they have supplemental insurance, then there may be some coverage there for that. At any age point, though, if they actually do have any kind of diabetic concern, so if they needed to be dilated for a cataract check, including diabetes, or if there's concern about macular edema, if there's a corneal problem, all of those things, that's considered a medically necessary assessment, and those ones would have medical coverage or Alberta healthcare, sorry, coverage for that. So it depends a little bit on sort of I guess, the type of examination. But very commonly, if someone were to, let's say, have diabetes, let's say go in there for their full examination, and so if they were to be brought back for, let's say, a glaucoma workup or a dilated fundus examination, there should be coverage for that. And then within that, if there are any kind of, co-pays, that kind of thing, then that may be something that their insurance may cover. But Alberta Healthcare does provide coverage for medically necessary assessments. And that goes beyond diabetes as well, too. Like if someone has like an infection or a risk of infection, let's say they have like a red eye that they don't really know what it is, whether they are diabetic or not, they still will have Alberta Healthcare coverage for that assessment. And then again, a lot of optometry clinics will have same day or same week appointments for those kind of triage appointments as well too. So
Thank you. We have lots of questions coming. We have three more
yeah.
so far. Rapid corrections of blood sugar. Any concerns with that worsening eye condition?
Yeah, so there can be for sure. Is if you think about it in terms of like a homeostatic balance, right? Any swings either way can be problematic, right? And so while we always want to see that blood sugar levels are lowered, I mean within a reasonable amount, seeing a diabetic sort of blood sugar level drop suddenly can also be problematic. And so this is not just to say that, of course, we have our hypoglycemic risks, right? But when we have swings like that, then the vasculature does respond in a way that can sometimes be a little bit problematic as well. Similarly, as well for the refractive errors. So it's not uncommon for when blood sugar levels are swinging that people's vision are all over the place, and that can be very, very challenging as well. We also will sometimes see this when in diabetic retinopathies as well too, just because they've had a sudden drop in that. That's why we do kind of like sort of the hemoglobin A1C as a better metric as opposed to a day-to-day blood sugar level. But just because there's swings up and down, or if it's a sort of rapid correction, like you say, sometimes there can be a sort of a vascular response, or sometimes the retina can more vasculature more than anything. There can be a bit of a rebounding effect that can happen. But in general, we want to see more stable long term. And so, if someone tells me, yeah, my sugars are plummeted and they're good, I usually will kind of wait a little bit to see if it holds as well too, right? And so the concern is that when there's a rapid shift in either direction, the body can, the homeostatic regulation generally only operates within a certain boundary, right? And so when you start to push beyond those boundaries, or when you kind of start swinging back and forth like that, in almost any condition, those swings at extremes are hardly ever a really good thing. So yeah, in all directions actually. And if you have a patient that there's a kind of a rapid control that's needed, certainly engage the optometrist to be able to see how we can monitor that, what that looks like from visual fields, from dilated fundus examinations. All that is fair game to assess how that patient is doing from a visual perspective as well.
Okay. With the uprise in GLP-1A use, have you witnessed an association of diabetic retinopathy in these patients? Can you explain the association and how to mitigate this risk?
Yeah. So I do think this is still, to be honest with you, I think this is still studies in the making, to be honest. There were many studies that talked about almost, it seemed like there was almost like an increase risk, like a positive kind of association with diabetic retinopathy with certain GLP-1 uses. And so the best I can understand right now, as far as that goes, for how to mitigate that risk, is honestly just a lot of monitoring. Because just like in any other medications that can have other impacts, think of like Plaquenil, for example, or think about like Dupixent, for example. When these medications are kind of necessary for the patient systemically, but there are also, the adverse events that have been reported, and at a fairly, relatively high level. I think it's a lot of that communication back and forth, which is going to be really critical because every patient does respond so differently, and I will not go out of scope to say to somebody, don't prescribe this medication before, before having them kind of gone through it, unless there is a substantial ocular risk, right? And so, I'm going to make an analogy over to someone who is on kind of any kind of hydroxyplaquenil, and we're monitoring, if there is any kind of retinal toxicity that's showing, then I will have that conversation with the rheumatologist and say, hey, this is starting to show up. I think, if there is anything else that can be done, let's try to explore that, and I can keep updating you on the ocular on side of things. And so from the optometry perspective, I think that if somebody is going to be starting a new medication that will have a risk of increased diabetic retinopathy as reported, then I think that the importance would be is having that conversation to set baselines and then tracking it over a series of time to see if it's happening. Because right now, I don't think we understand well enough who is going to be more likely to have that and who's not. And so, because there has been those benefits, I can't say that the medication should not be used, but I can't say that it's going to be like it's fine and we'll deal with it later kind of thing. I think that monitoring and that consistent reporting back and forth is really critical, and I think that's where that co-management piece really is helpful. And so that's a broader discussion to have, but when your local optometry clinics, I think it's really important to be able to establish kind of the hey, I'm going to start this patient on any medication, and then I'd love to be able to hear kind of a report back on how things are going, and be open to kind of getting that feedback from both sides, right? Oftentimes, like, I might get a suggestion, hey, this person's having a lot of dry eye problems from this medication. So I think it's really important to have that as that conversation, because that's currently from an evidence-based perspective, that would probably be the best way to mitigate risk at this time, until we continue to know a little bit more on the mechanisms and the pathophysiological mechanisms as to why the diabetic retinopathy can be a little bit higher in certain patients. Because we're not a retinal practice, I haven't seen that increase of diabetic retinopathy from that directly. I think there's some indirect associations there, so I can't comment so much on that. But I do think that is important because the primary care folks, the primary eye care folks, are going to see a lot of that in triage and send them to the right places. They may see a lot more association with that as well too. But we haven't conducted like a survey. But if helpful, we can certainly work with the PCNs to determine if that kind of a survey may be helpful to better understand that particular question as well.
Okay, so we have three more questions. Um, how would you like to proceed?
Well, what we could do, Megan, is that I think why don't we take all the questions that we don't have time for, and then
Okay,
we can put them into like a Q&A, like a FAQ that can go back to all attendees because I think there's a lot of really important discussion that we're having here.
I agree.
And so and what we can do is then I can actually anything that I don't know, I can actually go and look deeper because for example, going back to kind of the medication, the GLPs and retinopathy, I can go and actually look and see if there's anything recent within the last couple of months that's been published as well, and then we can talk about that a little bit more as well if there is anything. But I really love all these questions, so I think that we're having a really good dialogue about it. But why don't we collect any questions or anyone can send in questions that they have to the Alberta Association of Optometrists email, and then that we can make sure we get answers back to them with from our group.
Okay, so I am putting my email into the chat, and I will also be sending out the recording tomorrow to all attendees. So you can, yes, you will have access to the recording. Yeah. So you can respond to that email if you have any questions come up after that, and I will work with Dr. Leung to get you answers to the questions we didn't have time to answer today.
Perfect. Thank you so much to everybody for joining us. I hope the rest of your day goes well. And then, yeah, like Megan said, send in your questions. Even after this is all done, we're always a resource for you. So any way that we can help on a local patient care level and also kind of on a broader organizational level, please let us know.
Absolutely. Thank you for spending your lunch hour with us. A quick little survey will pop up when you exit Zoom. You can also use that to request a certificate of completion from the AAO, and we will have that to you next week. So take care, everybody, and I hope you have a wonderful rest of your day.
Bye.